All right, welcome back. I want to do a video lecture about the exam that we took. Everybody didn't do well on. It was kind of meant for that to happen. The exam questions were ones that were maybe poorly written, but some, most were not poorly written. They were just difficult questions. And so we need to go over it because it could be a sign of things that we're missing. Now, my voice is shot, and it's just the way it goes. But I've been thinking it's going to get better, and it's not. So the longer I wait, the longer I delay putting this out. So I'm sipping on some coffee here, trying to keep my voice kind of going. So if don't mean to irritate you guys if you hear that, but it's a necessity right now. So with that being said, let's take a look at a few things. Now, I'm not going question by question. I'm going by what I believe in the questions pointed out weaknesses. So we can go over the exam when you come back, but it's the subject material I think that's important. First thing is the vagus nerve. All right, so we need to talk about the vagus nerve and what it does and why it's important, etc. So let me flip over my notes. All right, so we have the vagus nerve. It's known as, it's a cranial nerve, number 10 to be exact. Okay. What I think is important about the vagus nerve, and you can read in your book, it's going to tell you a lot of stuff that it does. I recommend you doing that, but it causes, I guess what I'm trying to say is it's the highway for the parasympathetic response. All right, let me explain. And there is a syndrome known as Vasovagal Response, right? And what happens is sometimes if you, especially in guys at my age, if you need to go to the bathroom, need to urinate, you've been holding it, you run to the bathroom and, you start urinating, and it can cause a vasovagal response. And what happens is it's a bradycardia. Oh, hang on. Let me write this where you can see it. About that. Hang on 1 second. It's a bradycardia. All right. Because acetylcholine comes down the vagus nerve in response to that vagus nerve being stimulated. All right. And so it can cause that. When you think of vagus nerve, think of the parasympathetic response, think of acetylcholine. Okay. Those are the important things. The other thing to understand about the vagus nerve is the physiology of breathing. Here we have the vagus nerve here, and it stimulates the receptors at the diaphragm. And basically what it does is it says, hey, stop breathing in. Yeah, in order to exhale. Okay. So it does that. It tells the lungs, hey, hold on, don't inhale, let's exhale. Stop doing that. So it signals to inhibit respiration so that exhalation may occur. Remember, there's a question on the exam about atropine, right? And so here, let's say that we got this guy right. Well, let's just say, we can say this guy right here is bradycardic. All right. And so why is he bradycardic? Well, there's a big response here of acetylcholine coming from the vagus nerve. It's coming down the vagus nerve and it's affecting the electrical box of the heart, SA node, AV node. All right. And it's causing bradycardia. All right. And we'll talk more about it when we talk about neurological shock. But we can give some atropine. All right, we could give some atropine. And what's atropine going to do? It's going to cause a roadblock. Okay. It's going to cause a roadblock to acetylcholine. It's not going to allow acetylcholine to be able to be transmitted. Right. It's going to stop acetylcholine from going any further. And what happens then is the sympathetic nervous system. Okay. So then we have the response of the sympathetic nervous system. And when you think sympathetic nervous system, you think what? Epi, norepi, right? Alpha, beta. You're going to be able to get that beta 1 response only that increases heart rate. Let me shut my door 1 second. And nothing happens at headquarters until I do a video. Then everybody shows up to do everything. Okay, so that is how the vagus nerve works. Okay, we'll talk more about it in just a second when we talk about neurological shock. Right, let's go to the next. All righty, let's talk about the BVM for a second. There were some issues on the exam about it, and it comes down to this: one person BVM. What's the problem here with that? Well, we know it's a seal. There's always a seal issue, right? And the best way to use a BVM is right here with the two-person BVM. All right, well, that would be great, but it's just not going to happen. You know, we just don't have enough people to fit in the pre-hospital setting at the head a lot of times to make that happen. So what can we do? Well, this right here is the C-clamp. The C-clamp, and that helps us to maintain a tight seal by using the C-clamp. Take a look over here. This is a pocket mask, right? The patient's being ventilated with a pocket mask. Well, we're not ever going to do this either because of where we're at today with disease and that sort of thing. But the tidal volume is much better here with this as opposed to the BVM. All right. So it's better. All right. Tidal volume's better. Why? Well, it's better because we have two hands that are free, that we can maintain a seal, and we can really, provide an excellent seal, and we can see the chest rise and fall and all that. So yeah, on the exams, question was on there, and some folks picked the answer of a C-clamp being a problem, and we know C-clamp is just not a problem. Yeah, so I think they were a little confused by the pocket mask and probably couldn't see it, that it could actually do better at providing better tidal volume than a BVM, but it can. All right, let's move to the next. Okay, a little bit of confusion about the supraglottic airway, or it may not be called supraglottic airway, it could be called multi-lumen airway, but nonetheless, it's an advanced airway. All right, so let's talk about when we use this airway. When is it indicated? So it's indicated for airway management. All right, airway management of a deeply unconscious patient that is apneic. Okay, patient that's apneic without a gag reflex. All right. The next thing indicated for is for when the patient, if intubation, right? Intubation, endotracheal intubation is not possible or has failed, right? Or has failed. All right. So This is part of the emergency department. We keep these, if we try to intubate the patient, we have a problem, we have that as a rescue airway to insert until we can figure it out. So that's another indication. Let's talk about the contraindications. When can you not use it? Right. We talked about when you could use it. Now let's talk about when you can't use it. So we don't want to use it if the patient has a known pathologic condition of the esophagus. All right. So a contraindication would be a known pathological condition of the esophagus. So what could that be? What's a good example of that? Well, I think a good example of that would be esophageal varices. Esophageal varices. And so remember what esophageal varices causes, right? It causes lots of bleeding. You got a vein in the liver, doesn't have any valves, and you got blood coming up. It comes right up into the esophagus and causes a major airway problem. Who do we associate esophageal varices with? What medical history? What type of people? So this is going to be anyone that happens to have a history of alcoholism. Okay. So anyone with a history of alcohol, I misspelled that. Anyone with a history of alcoholism. All right. Because if they have a history of alcoholism, they are high risk for esophageal varices. All right. So something good to know. I don't think it'll be written like it was on the exam for registry, but you need to be able to associate alcoholism with esophageal varices. The book clearly, defines it. All right. Also, you don't want to give this as contraindicated for ingestion of a caustic substance. Let me give you all some room so you can see me writing here. So ingestion of a caustic substance, all right, would be a contraindication. All right. All right. So with that being said, let's move to the next one. All right, y'all, let's talk about neurogenic shock. All right, neurogenic shock. Let's don't forget about the vagus nerve over here. All right. Don't forget about the vagus nerve. And because it plays a role in neurogenic shock, what ends up happening is with neurogenic shock, it's usually a result of a spinal cord injury. Right? Usually a spinal cord injury. And what ends up happening is we end up losing a normal sympathetic response, right? And so we need the sympathetic nervous system here, but it's nowhere to be found. What does the sympathetic nervous system help us do? Help us to control the size and the diameter of blood vessels, right? And remember, it helps to stimulate breathing to be able to exhale, right? And so that's what's going on here. And basically what's happening is the parasympathetic nervous system is left unopposed, really. It's just unopposed. you know, the good thing about having, well, not the good, the necessary thing about having both is if I'm too fast of a heart rate, parasympathetic comes in and slows it down. If it's too slow, the sympathetic nervous system initiates and makes it normal. You got to have both of them responding. Well, in this case, in neurogenic shock, we don't, right? And so that's why we'll end up having a low blood pressure, right? Because of vessel dilation, but we'll also be bradycardic. Let me move this up a little bit. And we'll also be bradycardic, right? Slow heart rate, low blood pressure. It doesn't make sense, does it? Doesn't normally go that way. But it does today when neurogenic shock. So we talk about something on the exam called fluid refractory hypotension. Fluid refractory, right? Fluid refractory hypotension. All right. And so what this means is vessels are dilated and the fluid, you're not going to be able to really dump enough fluid in here, right, through an IV to make a difference, right? We need something else. We need to fix the size of the vessel in order to fix it. So it's fluid refractory hypotension, okay? All right, move into the next one. All right, let's talk about the lymphatic system really quick. Might be some confusion out there about it. All right, so what does the lymphatic system do? What's its function? All right, and it's got a couple. Basically, let's just make it real simple here. Fluid balance and infection. Fluid balance and infection control, okay? A couple of things you need to know about it. All right, so what is lymph, right? What is it? Well, lymph right here is plasma-like fluid. Plasma-like fluid that forms in the interstitial or extracellular space. So plasma-like fluid in the, I'm just going to put extracellular space, or maybe I'll do like maybe I'll just call it ECF. All right, ECF, right? And so here you go. See all these green lines over here are actual, that is your lymphatic system. It's got its own circulatory system. And so here, over here in this picture, you know what? Let me see if I can get I'm going to pause you 1 second. All right, I'm back. So I got my pointer here. So you see what we have here is the lymphatic system. This is the lymphatic vessels. You have lymph nodes. I don't know if you've ever felt your lymph node being swollen or painful, but sometimes it happens. And that's because it collects a piece of lymph that's infected, and it stops it in one of your lymph nodes. Okay. But if you look over here, you see that you have your vein, you have an artery right here, and then you have your lymphatic system. And right here, this is like what do you call this? The tan cells are like the extracellular space. Right. So they're taking fluid from that extracellular space. And so we can have white blood cells in this as well to fight infection. And what ends up happening at the end of the day is this thoracic duct right here dumps that fluid back into the internal jugular, right? Or the subclavian. Hang on, let me look at my notes real quick. Thoracic duct empties into the left subclavian vein or left internal jugular. Yeah. All right. So plasma-like fluid, extracellular space, ECF. Let's see here. What else do I want to say about this? That's pretty much it. That's pretty much it for the lymphatic system, okay? All right, let's go to the next. Okay, let's talk about really quick some OB stuff that needs to be talked about, I believe. All right, so gestation, right? The process of fetal development following fertilization of an egg. All right, that's one term you need to be aware of. Fertilization, that's right. That's where the sperm and the egg meet in the egg. All right, I think you guys need to, excuse me, know those defs. All right, know those definitions. All right, the placenta. What's the function of the placenta? Right, what does it do? Well, it's an early liver for the baby. Right? All right, it provides that respiratory gas exchange. All righty. That's super important. All right, gets rid of waste. All right, we're going to be able to get rid of waste here. All right, and heat. So temperature control. All important. All right, so that's something you need to know that. The umbilical cord, right, connects to the placenta, correct? It better. So the umbilical cord. All right, and so it has how many veins? All right, so 2 veins, 1 artery. We need to understand that the vein carries oxygen-rich blood from the placenta to the fetus. All right, so it's going to carry oxygen to the fetus. Okay. Talk about gestation period. All right, the gestation period is how many weeks? How many weeks? All right, so it's kind of like 38 weeks. But then when you add the last menstrual cycle of the patient, it ends up being 40 weeks. How many trimesters? There's 3 trimesters, right? Need to know when those are. All right, you need to know when those are. We need to know when the trimesters are, so let's look at that real quick. So your first trimester is from conception till what, 12 weeks, I believe. Yep, now through week 12. Let me slide this over a little bit so you can see me right. Whoops. All right, now then, let's look at the second trimester. All right, so this is the first right here. Here's number 2. So number 2 is going to be 13th week. To the 27th week. All right, and then the third, whoops. And then the third trimester, we're going to say week 28. All right, till delivery, week 40. All right. And so it's important also to know about things that are going on during that time frame. Like third trimester, right? When the baby moves into the pelvic inlet, what do we call that? Lightning, right? No, lightning. I ain't talking about thunder, I'm talking about lightning. All right. So lightning, what's happening here? Week 25. Surfactant, okay? Why is surfactant important? Well, you couldn't breathe. I mean, the baby can't breathe without lungs. And so when the baby's delivered, if by week 25, hopefully if they come that early, then it could be viable. Maybe. So we need to talk about the mama here for a second. We need to talk about mom. We need to talk about some maternal changes. All right, some maternal changes in mom. All right, so total blood volume. All right, it's going to increase by 50%. All right, 50%. All right, by the 40th week. All right, we're going to have an increase in red blood cells. All right, they're going to increase by about 30%. Why is that important? All right, so what do red blood cells do? All right, so they obviously, we know they carry oxygen. Okay. And it's actually the hemoglobin that does that, right? It's actually the hemoglobin that carries the oxygen. But what seats the oxygen in hemoglobin? So like, let's see, let's do a little hemoglobin. All right, so inside the red blood cell, there's hemoglobin, right? All right. And so there's 4 seats for oxygen to ride in. 1, 2, 3, 4. That's why they say, you know, if you're low on red blood cells or you're low on hemoglobin, you might only be oxygenated by 50%, right? So you would only have 2 seats here filled up with oxygen. All right, but what holds the oxygen, it's kind of like a seat belt. What holds the oxygen in, this little strap here, right? And that little strap is called iron. All right, so if we're increasing red blood cells by 30%, that means hemoglobin has to increase. It also means that iron has to increase. Now, wouldn't you know that most all females, all right, most all females are iron deficient. All right, they're iron deficient. How's that so? Why, Instructor Morris? Tell us, why are most all females iron deficient? Well, that's because they menstruate monthly. And when they menstruate, they're losing blood. And what's in blood? Iron. All right, so that's an issue. All right. And so what they noticed was they had all these babies being born either premature, they were having a bunch of miscarriages. And some smart paramedic said, you know what? I wonder if it's because of the iron. No, it wasn't a paramedic. It was a doctor, but same thing. So they started giving females iron supplements while they were pregnant. And wouldn't you know, it decreased premature babies. It decreased the amount of miscarriages. And so that's why all these ladies have to take iron when they're pregnant. Exactly right. So that's why it's important with those red blood cells going up. More room here. All right. Here we go. What else happens? So the heart rate. A black pen. Heart rate's going to go up or down? It's going up. Heart rate is going up by how much? About 10 to 20 beats per minute. All right. So what about cardiac output? What about cardiac output? It's going up too. Yep. Cardiac output's going up by about 30 to 50%. All right, and that depends on what week of the pregnancy that they're in. All right, why? Because by the 22nd week, they're going to be at 50%, the highest you can be. It'll be 50% more cardiac output. So there's still going to be 30% more cardiac output. It's just going to, at birth, it just goes down a little bit. All right. Okay. We're doing good. These are things that you guys need to get. Maybe you already got them. If you do, great. If not, get them now. Okay, get them now. Blood pressure. We're talking about systolic and diastolic. All right. Blood pressure. Oh, Lord. I misspelled that bad. I'll correct it. All right, look. All right, so systolic and diastolic. Blood pressure is going to go down by 10 to 15 millimeters mercury. All right, this is going to happen by the second trimester. All right. And become near normal all right, near normal at delivery. All right. And don't forget, too, one of the problems that we have in the second and third trimester all right. Second and third trimester is that supine hypotension. Right. And that's where the baby is on that inferior vena cava. All right. And we can change that with positioning. Our respiratory rate. Respiratory rate's going to increase by 40%. All right. What about CO2? If I was writing the National Registry, I would ask this. Because this is something as an AEMT you guys have studied about, right? Is acidosis alkalosis. And so it should be a fair question to ask. What about CO2? Right? And so what ends up happening is there's going to be an increase in CO2. All right. The patient, couple things going on. All right, couple things going on. One, they have this baby that's growing inside their stomach, right? Well, not their stomach, but you know what I'm talking about. It's growing inside the pelvic cavity, and it's pressing down on the diaphragm, right? It's pressing on the diaphragm. All right, and so that's gonna sometimes actually decrease tidal volume and increase respirations. So the patient can actually become respiratory alkalotic, but they can become metabolically acidotic. Yep. Because and they're breathing out a lot of CO2, but they're retaining a lot of CO2. Right? So it's just sometimes that happens that way. Something to think about. All right, when you're thinking about that. So tidal volume can decrease depending on the anatomy of the baby. All right, so they could be alkalotic, acidotic for that reason. All right, what else? Well, there's going to be an increase in CO2. Why? What's another reason? Well, the baby CO2 from the placenta, right, is transferred to mom. There you go. I mean, you got even more CO2 because of that. Something to think about. All right. And so let's talk about morning sickness. When does that normally occur? When does morning sickness normally occur? Right. Bloom got it right. He got it right. Good job, Bloom. 8th and 14th week. Okay. 8th and 14th week of pregnancy. During that time, what happens is the stomach and intestines are compressed. All right, they're compressed and they're pushing up superiorly, and that is causing something known as heartburn or acid burn. Okay. All right, and so also, if that wasn't bad enough, women that are pregnant suffer from constipation. Right. And they suffer from that because there is peristalsis. I think that's right. Peristalsis. Right. That's that motion, that rhythmic motion that helps waste move out of the intestine, right? It helps waste move out of the colon. Well, peristalsis is decreased. Probably because there's a big old baby on top of it. So, all right. All right, and then the normal weight gain for a female patient is usually about 27 pounds. All right, that's all I got for pregnancy. Hang on one second. Let me see what else we got. All right, last, I want to talk about this real quick and we'll be done. All right, what's fetal distress? Fetal distress. Somebody besides Bloom. All right, so it's caused by hypoxia. Caused by hypoxia, right? And that could be from a number of things: a nuchal cord, trauma, abrupto placenta, prolapse cord, right? Well, it shows itself by bradycardia. So anytime you have a patient that's bradycardic, they are in fetal distress. That's about all I have. I'll talk about a few other things in class, but that's it. All right, it gives y'all something to look at. Something to look at. So let's look at this stuff. Let's learn this stuff, and let's do really good on our registry exam. All right. Thank you.